Welcome to those of you who are joining me live here for our another one of our free monthly wellness webinars. This month we'll be talking about diabetes awareness and prevention. And as we go through the slides, I'll explain a lot of stuff that has to do with this particular topic and talk a little bit more about who I am as well. But first, I always like to start off with some objectives. This may be, if you were here with us last year, a refresher, or this could be some new information that you're going to learn today. So hopefully you'll find it educational and informational. And what we're hoping you get out of this today is to recognize the differences among the different types of diabetes. Share with you some language maybe that you haven't heard before when it comes to the diagnoses, learning some simple, sustainable habits to help manage this condition and hopefully prevent it from happening. And also, I'm going to dive a little bit deeper into the GLP-1 medications because we talked about that in last year's webinar, but honestly, a lot of stuff has happened since then. So I wanted to make sure I give you some updated information. And then last but not least, go over some common myths and misinformation just to make sure you feel clear on what to know about this condition. So some housekeeping things first. Before I introduce myself, the session, as you might have heard when you came in, is recorded. That's because a lot of people sign up for this. Some people attend live. Most people end up getting the recording after the event is done in about, I don't know, a handful of days or a week or so after the event. I usually send out the recording link with a thank you, and I send out an email survey link, I should say, to get some feedback from all of you as to how you think we did, and also if there's any future topics you want to learn about. And then in about a few months' time, I post the recording directly to the DishWithDina YouTube channel so that it's available for public viewing because we like to make our free content available for anyone out there. You can, as I was saying before, I am flying solo today, so you can put questions, comments, feedback in the chat if you'd like. I may ask you some questions along the way. There's also usually about 5 to 10 minutes time left at the end of the webinars for any Q&A. Obviously, I want you to take away from this education information, but not medical advice. Please make sure that you are working with your own healthcare providers if there's anything in particular that you need to pay attention to or before you start or make any kind of adjustments to your own physical and mental health routines. So this is me. If we've never met before, hello, my name is Dina D'Alessandro. I am a registered dietitian, also known as a nutritionist. And for those of you who do know me, I'm not going to bother you with all of the details that you see on screen here, but I just wanted to share a little bit about my own personal experience when it comes to this particular condition. My very first job when I became a dietitian, oh gosh, it's close to almost 9.5, 10 years ago at this point, was in a high-risk OBGYN office where I was dealing with a lot of patient populations who were being diagnosed with what's known as gestational diabetes, which we'll talk about in a sec. And I also had a 2-year stint in one of our local health centers here where I was trained not once but twice through the CDC's Prevent Type 2 National Diabetes Prevention Program. So they have a curriculum that we had workshops every week. We would meet for an entire year with people who were at risk for developing type 2 diabetes. And so I feel, suffice it to say, while I'm always growing and learning, I consider myself to be an expert in some things, but there's always room for improvement and room for knowledge. But at this point, I can say I probably have dealt with about 1,000 or more, maybe more than that in the 9 years, maybe thousands of people who have been dealing with diabetes, have a family history of it, are at risk, or at told that they are borderline in that diagnosis. Excuse me. So tomorrow, today's the recording. So today the live event is happening on November 13th, but tomorrow is World Diabetes Day. And this is because we have about 38 million Americans that are currently diagnosed with diabetes and a global projection, unfortunately, of about 780 million who will be diagnosed with this condition by the year 2045. So we really try to draw awareness and prevention and provide tips and information and make sure that you get all of the information ahead of time so that you can keep in touch with your healthcare providers and keep on top of this condition if you are diagnosed with it. There is no cure for this. So that's something that comes up a lot. A lot of people think that you can. Unfortunately, the way that this particular condition works, you can go into remission. It can be kind of latent, but there could be possibility of it coming back in the future. So it's always important that while you may have success in managing and you are quote unquote in the clear at some point, we want to make sure that you are preventing it from recurring or progressing into something a little bit more complicated. So a lot of times just, lifestyle changes can help depending on the type of diabetes that you are currently diagnosed with or trying to manage. Diabetes Month, Awareness Month, is actually in November, so that's this month as well. So this ties in again to raising awareness, education, prevention, and effective management of the condition itself. So on to the next slide here, like what even is it? Like how do we define what diabetes is? So this is a chronic condition, as I mentioned. We'll talk a little bit about specific diagnoses in a sec. But generally speaking, this is a person's blood glucose level, or what's known as blood sugar levels, when they are consistently elevated through no fault of their own. Something's going on, their body's a little bit wonky, and we'll see in a sec when I discuss the actual diagnosis names as to why that might happen. So that blood glucose that's happening in your body is going to be managed through something known as insulin that helps with regulating our blood glucose. And then unfortunately, poor control or poor management of that, whether you're on medication, you're trying to implement lifestyle changes, can lead to complications down the line, like heart issues, kidney issues, and even unfortunately, sometimes like amputations, because we're talking about a very vascular system. We're talking about the blood system. So if there is poor control or poor management, the blood does not get to where it needs to go in the extremities of our bodies, and then that ends up causing things that have to be unfortunately amputated. So let's talk about, I always like to give a little anatomy picture here. So what you're seeing on screen is the pancreas, and within that pancreas, we have what are known as the beta cells, and those are the things that produce this hormone known as insulin, and insulin acts against or helps counteract the hormone known as glucagon. So when we eat, glucagon rises, insulin comes out and helps lower that blood sugar level and forces the blood sugar out of the bloodstream into the cells where it can be utilized and processed and be turned into energy. So when we have this unfortunate situation, like in the case of type 1 diabetes, that is where you have an actual autoimmune condition where your body is just not making any insulin at all. Maybe you were born with a faulty pancreas, or maybe you contracted a virus of some sort that caused an infection that ended up affecting the pancreas, and then that insulin just isn't made. So in the case of type 1, insulin management is absolutely essential in order to keep somebody alive. So we'll talk a little bit in a second about the medications and how people manage their diabetes diagnoses. Pre-diabetes is kind of when you're on the border. I'll show you in a minute how we get diagnosed and what those blood tests are. And that's just, again, a preliminary discussion to have that we want to make sure it doesn't progress into type 2. And then type 2 diabetes is more lifestyle related. Now, type 1, while I said you could be born with it, sometimes people are of higher, older ages when they are diagnosed with it. Again, it could depend on if there's a virus or something complicated that happened, but usually we see a younger version of that. And then type 2 we see in the older population. But as it is right now, because diabetes is so prevalent, we've actually started seeing type 2 or pre-diabetes happen in the younger adults or younger children too, somewhere along like I think 12 or 13 is going to be kind of common in order to see that. So usually with pre-diabetes and type 2, we're really talking about lifestyle modifications and management. You may be given medicine for this, but usually we try to make sure we take the path of least resistance there. Gestational diabetes, as I mentioned earlier, that is just the mere fact of being pregnant can put somebody at risk for gestational diabetes. They get tested around weeks 24 to 28, and if they don't pass that blood test, then they get diagnosed with what's known as gestational diabetes. It could clear after the baby is born, but it can also put the person at risk and the baby at risk also for type 2 after the fact. Not every pregnant person gets gestational diabetes, and not every pregnant person with gestational diabetes gets it in every pregnancy. So again, it's very, very specific and very individualized, as most conditions are. And then the last one here that I wanted to share too, so I mentioned this last year and I haven't really gotten much update on this, but type 3 diabetes is what we're starting to see termed as cognitive decline or Alzheimer's disease. So it's possible in future research and different future recommendations that you might see that terminology come up. So I thought I would just mention that here. What is not pictured on this slide, and forgive me for reading my notes because there's a ton of information that I have in front of me, what's not listed on this slide is we're also noticing a variety and combinations of terminologies that are also coming to play with this particular disease state or diagnosis. So we have something known as latent autoimmune diabetes, which kind of mirrors both or straddles both type 1 and type 2. And that sometimes is known as type 1.5. So the issue here, complication here, is that somebody is not being treated properly for it or getting the proper, receiving the right treatment. So what I tell people is if you think particular management, treatment, diagnosis is not working for you, make sure you go back to the drawing board with your healthcare provider and just see if maybe you're on that cusp, maybe you're on that borderline, because that can, unfortunately, if you're poorly managing those things, that can lead to, as I said before, some complications like kidney issues, amputations, and something known as diabetes related ketoacidosis, which is your body's way of breaking down your body fat to utilize as energy, but not in the the trending keto diet trend, more in the sense of it's a very complicated condition that your liver ends up suffering the consequences. I've also came across 5 subgroups of type 1 and type 2 because these names haven't changed in a really long time. And I know not just in the healthcare provider world, but I also know in the patient world, we hate when we get name changes when they're much harder. So in front of me, I have groups 1 through 5, which are known as severe autoimmune diabetes, severe insulin resistance diabetes, mild age-related diabetes, and a couple of other ones as well. So it's possible that if you are, over the course of the coming years, receiving diagnoses or living with or helping somebody who is diagnosed with diabetes, that you might start seeing these group specifications come out. So I thought that would just be helpful to share with you. Some risk factors, I mean, the typical things that come in place. Like I said, with type 1, the risk factor is just, it is what it is. It's an autoimmune condition. But with type 2 and pre-diabetes, there are quite a combination of things going on here. So I never share this with anybody to scare them into how to be on track with preventing something from happening. But if you are noticing some things taking place, if you are noticing some changes in your health and trying to be conscientious, then again, that ounce of prevention could hopefully help with reducing the risk of having this progress into something more complicated. So I try to be really, really sensitive around the discussion around weight, overweight, obesity, body fat, but there are some correlations that could be a risk factor, but so can many other things like your age, like your level of physical activity, and whether or not your pancreas is just working properly or not. So in the case of type 2 or pre-diabetes, you might see it be called insulin resistance or insulin sensitivity, meaning that it's not making enough insulin for your body to end up counteracting the food that we're eating. So again, that could just be a sluggish condition, which hopefully some medication or lifestyle management can help with managing that condition for you. Here too, some of the warning signs. So again, not to scare anybody, because sometimes things like this, extreme fatigue. Hello, right? I know some of you who are online with me right now or have registered for this are my students, and I know how you pull all-nighters and cram for your exams and so on. So you might just naturally be extremely fatigued. But we're really talking about patterns and things that feel like they're not well explained. So involuntary things that are happening, or again, patterns of things. So keeping an eye out, or maybe even a log of signs and symptoms that you can bring to the attention of a doctor, just to share this is what's going on over the course of the last X amount of time. And then this way you can all decide whether or not you need to look into this more deeply to see if there is an issue here related to your blood sugar, your insulin, or anything else that might be related to potentially increasing your risk of getting diabetes. Now, how we diagnose it is listed here as well. What we usually do, or what the doctors do, not me, what the doctors do is they give you a blood test. There's one called a fasting blood glucose or fasting plasma glucose. You might see different names for this. You can see it here listed in the middle as fasting blood sugar test, and or what's known as a hemoglobin A1C. So the reason why I posted this particular image is because on your lab reports, you might see different numbers within range or out of range. And sometimes you'll see the units of measurement be a percentage, and other times you might see the unit of measurement be milligrams per deciliter. So again, these numbers just tell you whether you're within normal range, you're on that borderline of prediabetes, or you have been diagnosed with diabetes proper. Usually, again, here it's more type 2, not type 1. Glucose tolerance test, which is over on the right-hand side, that's something that's given to the pregnant population, as I mentioned, to indicate whether or not you are diagnosed with gestational diabetes. All right, so treatment and management, early detection of anything is going to really help improve your outcomes. So I realize it's not very easy for a lot of us to take off time, or maybe we don't have the insurance that covers our screenings or our doctor's visits, but sometimes those things are free. As like, your wellness visit might be covered or given for free depending on who you're working with. And so as often as you possibly can, keeping up with your regularly scheduled annual exams, that would be helpful because odds are in your standard blood test, you're going to see something like hemoglobin A1C, and that'll be able to tell you the early warning signs. Prevention of complications, like I said before, if you see things progressing, if you have patterns of signs and symptoms happening, getting in front of that before it gets to be too complicated is always the guidance there. The healthy habits of extending that lifespan, incorporating as much as possible that you are in control of. And of course, we also have some modern medicine, technology, etc., that can also help provide you with better tools, education to make sure that your outcomes are good to go. Now, with that said, I want to point out a couple of things here. So we have two images on screen. The left-hand side is the CDCES. This is a certification specifically for people who want to provide diabetes care and education. They are specialists in that. It used to be called diabetes educator, I think, certified diabetes educator, a CDE. And again, we like to fill things up and make more letters. What you usually do when you're dealing with a diabetes diagnosis is, yes, you might go to your primary care physician, but you also might be dealing with an endocrinologist because we're talking about the hormone system, and that's who handles that. So that's your specialty person in the endocrinology field. And then you might also be referred out to a dietitian. Now, some of us might have this certification and some of us might not. This certification, the requirement for it is you have a certain amount of hours of experience dealing with face-to-face counseling somebody with diabetes. You have to understand the medications as well. There is a cost affiliated with that too. What else is new when you're trying to get letters after your name? And anybody in the health and wellness field can receive this with those requirements met. So you'll usually see maybe registered nurses, advanced practice nurses, registered dietitians as well. But even pharmacists and physicians too, or other healthcare professionals that are interested, they've had the experience and they want to go for that. Now, here's where I always like to share too, as I do in almost every webinar, the social determinants of health. I just got done saying in that past slide, healthy habits, whatever's in your control, try to get ahead of things. But we want to recognize something known as healthism, which means we're putting the responsibility of health and lifestyle modifications and outcomes on the individual when we know they aren't always in control of certain things. So we're talking about people who might be suffering from economic instability, food insecurity, healthcare access, both quality and maybe even location-wise, neighborhoods, environments, infrastructures, things that don't allow people to get to where they need to go or allow them to be able to access certain things to help them manage their disease states or help support their overall health. And of course, the social and community context as well. So whenever I talk about stuff like this, whenever I give you guidance about, do this, don't do this, or reduce this and increase that, I always try to make sure I acknowledge those social determinants of health because sometimes things are just not within your control, and we want to make sure that you are aware of that and that your healthcare providers are aware of that too. So this way, if you are dealing with some sort of hardships, possibly you can receive some resources or outreach or work with a social worker or be put in touch with somebody who can help you to make sure that your outcomes can be proper there. Okay. So next up, I'm going to share with you the medications that you see on screen here, both what is considered non-insulin or insulin-dependent medication treatments. And sometimes there's a mix of certain things, but usually depending on the diagnosis, you're going to receive one or the other. So the non-insulin medications, those are going to do what is known as lowering your blood glucose or your blood sugar level. So they come in and they help decrease that blood sugar that is running through your bloodstream. And some of these options can be taken by mouth, and some of these options might be injected. If you've heard the terms of these before, something known as metformin, that's kind of popular. There's also the SGL2 inhibitor, and there's also something known as a sulfonylurea. So each one of these will do one of three things. They'll either help with reducing that blood sugar level, they'll decrease the amount that is produced in the liver, in your body, and they'll also help increase the sensitivity of your tissues to get what needs to be delivered for it as far as the natural insulin that's occurring in your body. The inhibitors, right? So something that's blocking a particular action. So the inhibitors will block the insulin, the action of having the glucose in the bloodstream, so it's being reabsorbed by the kidneys, so that the excess glucose isn't running around in your bloodstream. And instead, it's eliminated through kidneys, bladder, and urine. And then those sulfonylureas, those stimulate those beta cells, the things that are in your pancreas that produce that insulin. So it helps with increasing the production of insulin in order to get to where it needs to go. The right-hand side, so insulin itself, that's sometimes a scary thing that people hear, but in the case of type 1, I mean, that's your life-saving situation here, right? This is always going to be man-made or synthetic. It's a synthetic version of the natural hormone that we don't have in our body if we're dealing with something like type 1 diabetes. So these will usually be done through injection or through what is known as a pump, where somebody's actually wearing a piece of medical equipment on them, and there is something that's inserted into their body, and then they dial it up, dial it down, and it provides them with the amount of insulin that they need every day to keep them alive, to offset what is going on in their body when they eat. So I'll talk a little bit more about some of the other things that are related to both type 1 and type 2, but usually type 1 is always going to be immediate insulin because that's the life-saving management there. Type 2, maybe the doctor might offer this, but usually they'll do something more oral, or they'll stick with the lifestyle modifications first. But in the case, if you are doing anything that is given to you by your doctor and you're doing a medication like this, they'll usually also ask you to check your blood sugar through finger sticks, or what's known as a continuous glucose monitor, or something that you actually stick to and it kind of pricks into your skin. You have to make sure it's clean, and you change it every so often. And nowadays there's an app for that. So you'll usually get an automatic response reading from that, and you can see immediately how your blood sugars are affected over the course of the day. Food or other things. All right, I'm going to talk about GLP-1s. I'm not going to go super into detail in here. I just want to give a little bit of an understanding of what this is. So GLP stands for glucagon like peptides. This is a natural occurring hormone that happens in our gastrointestinal system, that when we eat, it produces this thing that is in response to our eating. And again, we're talking about blood sugar levels versus the glucagon, right? Glucagon increases the blood sugar in our system, and insulin comes and decreases that to kind of offset that and send it off on its merry way. So the GLP-1 medications are helping mimic that hormone and then doing the job of what our body should be doing if it's not doing it on its own. As you can see here, it does help with lowering that blood sugar levels. But from the people with whom I've worked, and from a lot of the side effects that we're starting to see, because nowadays, and you'll see on the next screen in a second, where yes, it's supposed to be a diabetes medication, but because the side effect sometimes is weight loss, and our society is very fat phobic, I guess we can call it. And unfortunately, a lot of our medicines will say, and they like to share, that some of the side effects are promoting weight loss, that now this is being used as a weight loss drug as well. So some people with diabetes who need this to support their condition are finding lesser inventory. Sometimes it's unavailable because other people are utilizing it as a weight loss drug. So what happens is the pharmaceutical companies have divvied it up, and I'll share with you in a second the different brand names of what those GLP-1s are. So here we have, as I was saying before, with the side effects too, from what I'm seeing from some of the people I treat with diabetes and or weight management who are using GLP-1s, they completely lose their appetite. It just completely shuts off, which is not great. I mean, yes, you're going to lose weight whenever you're restricting your diet, unfortunately, but we definitely don't want people losing that connection of hunger and fullness cues. So people end up just saying, like, I'm not really hungry, as you can see there, right in that bullet. And what's important here is that it's not just an end all be all. This is part of a treatment plan. So if anybody is on this, I really, really, really recommend that they're working with a dietitian, maybe even an eating disorder behavioral specialist or somebody in therapy, to understand a little bit more about those cues. And of course, going to see their endocrinologist or their primary care physician to make sure that they're staying on top of things. So again, it's just one part of this treatment plan. You might have even heard of something called Ozempic face. So Ozempic tends to be kind of one of those name brands that we hear a lot. And that's also one of the side effects too, that not only is it reducing weight, and when we say weight, we usually mean excess body fat, but unfortunately it may also deplete the protein in our body too, which is not what we want. We don't want people losing muscle mass. We don't want that to happen. If we're losing anything, body fat is usually the thing that is okay to go, again, within reason, but we definitely don't want people losing their muscle. And sometimes you'll see that in the face kind of be very, very skinny or emaciated in that way. Other side effects could be rare bowel obstructions and pancreatitis and some other inflammatory issues as well. All right, so here I just thought I'd share on screen some of the brand names that you might be familiar with, something like Ozempic, as I said, Wegovy. I see that commercial every flippin' day. Mounjaro's another popular one. Zepbound and Trulicity, I think are. But on the right-hand side, you can see there that their approved uses are some type 2 diabetes and some are weight loss. It's a higher dose or version of it. So some people who are put on these products will be told to quote unquote microdose so that it does its job with helping the insulin. It may also have that side effect of weight management, but it's not doing it to the extreme where you're completely losing your connection to hunger and fullness. All right, so let's get into what ties into all of this. When we talk about diabetes, I think the first thing people think about all the time is carbohydrates. You're not wrong. You're not wrong. Obviously, this is essential nutrient when it comes to our macronutrients, those large size molecules that provide us with our food and our calories, also known as energy. Carbs are very, very important. They help us do, look, even this, right? All this stuff, that's carbohydrates at work. Me breathing, my heart, carbs at work. So these are essential nutrients. This is your immediate and main source of energy. Energy as in putting fuel in the car that is your body to help you move around and go. These are found in a wide variety of foods, usually only plant-based items here. I think sometimes when people think of carbs, they just tend to focus more on the starchy or the grain-based, but really carbs are in everything. Even milk has carbohydrates. Bonus points if you know what a carbohydrate in milk is. That is your lactose. That is the naturally occurring milk sugar found in milk. But animal products otherwise do not have carbohydrates in them. So let's move on to some of the mental management approaches or lifestyle modifications that are utilized if somebody is managing their diabetes. Just, you know what? I think some of these approaches I think are quite helpful and useful anyway. When we're making meals, making sure we're eating a well-balanced diet. We always talk about diversifying our diet too, eating a wide variety of foods, fruits, vegetables, etc. So here is what is known as the plate method. And the focus is on this kind of like this proportion. So you have different food groups, and we have some examples of the food groups listed. And the plate itself is supposed to be contained in like a 9-inch plate instead of something much larger, like a 12-inch plate, which some people might have at home. So just kind of keeping it portion appropriate here. And we'll talk a little bit too about portions in a second. But you can see up in the right-hand quarter of that section of that plate, that's where your grain-based foods or your starchy foods are. Left-hand side is full of those more lower calorie fibrous types of fruits and or vegetables, like you can see on the left-hand side there. You have like your leafy greens and your tomatoes and your salads and things. And then bottom right, you have your protein sources. So here we have an animal version of that, but there could also be plant versions of it too. Just keep in mind that plant versions will also have carbohydrates, like beans are a great example of a fantastic source of plant-based protein, very high in fiber, but they are also a bit starchy and they do have carbs. So if we are monitoring and managing our carbohydrates while we're trying to manage our diabetes, that's just something to take into consideration. So I'll speak about that in a sec. But one thing I wanted to point out, and I see in the chat in a second, let me jump in there in a sec. One thing that I wanted to point out with this here is when people look at this plate, I think a lot of times they go, oh gosh, that's not enough food for me. But the point of this is to help you with your balance to make sure that the carbs aren't hitting as quickly as if you were just piling up those carb-based or grain-based or starchy types of foods. So I tend to tell people, whenever you're eating anything, just grab a little something of each of these food groups. Make sure everything's represented on your plate. Allow yourself to digest, have some water, maybe mingle, move around a bit, And then if you're still feeling hungry, go back for part two. That's totally fine, but just make sure you're trying to do this again. Capture that balance again. Okay, let me jump over into the chat just to see if yeah, exactly. There you go, Natalia. Thank you. Yep, thank you for that. Yeah, you know what? I didn't include in here specifically label reading, but I'll talk a little bit more about that in a second when it comes to carbohydrates and the grams in those things too. So thank you for pointing that out. Yeah. Okay, so next up here, similar, kind of like a part two, speaking of part twos, part two of that portion, that balanced plate. I am not a huge fan of weighing, measuring, and tracking every single morsel. I think sometimes that lends itself to disordered eating habits, or if somebody is already dealing with a not great relationship with food, it can make them feel a little bit obsessive or triggered in that way. So I tend to say, like you saw on that plate, just use your hand. Maybe just like whatever fits in the palm of your hand, kind of a cupped palm of your hand, or whatever is the size of a fist is like a serving size of it. So again, right, you're just kind of plopping a little bit of everything on your plate, making sure obviously you're being more conscientious if you want to double up on your protein or be mindful of anything that might be kind of high in saturated fat, that you kind of limit those things. But I think this is kind of a good, ooh, pun intended, rule of thumb to utilize something like this to give yourself an idea of how much you can eat. Now, I know an example I give a lot of times too, and then that plate that you saw earlier, I mean, if you have a rice-based diet, right? A lot, globally speaking, rice is a culturally staple. It's a cultural staple food, and for me, I'm Italian. Pasta is our staple food. Do you see how small that tiny little thing was on the side there? But again, the point is it's portion appropriate. I can add other things to my plate, make sure there's a representation of everything, and then if I'm still hungry later, I can kind of go back for round two. Versus eating an entire plate of just the starchy, carby, grain-based things, and then have it affect my blood sugar, especially if I'm managing my diabetes. All right, next up, I want to share with you meal timing. So if, what was it, my meal planning? I can't remember where we talked about this last. I bring it up a lot, but I tend to tell people if you know how many calories is in something, that's a good indication to understand a little bit more about how your body is behaving. Generally, a good guidance is about 100 calories balanced, meaning a carb, a fat, and a protein. About 100 calories should equal about an hour's worth of energy before you start feeling hungry again. So if you have a very, very grain-based or carb-heavy type of meal, because it's an immediate source of energy, it's going to be utilized very quickly. So 200 calories is going to go a lot quicker in your body. It's going to be utilized a lot quicker in your body, and you'll feel hungry sooner than if you have the proteins and the fats added to that. So you can, spoiler alert, I'm going to share with you later on some of the other webinars that we have, but you can always go into the YouTube channel to learn a little bit more about the macronutrients and helping you meal plan. But the general guidance is you don't have to eat within seconds of waking up. Usually we try to say within a few hours after you've woken up. Some people with blood sugar issues, and I'll talk about this in a second, have some early morning conditions where they have to let their blood sugar settle down again. But generally speaking, within a few hours is fine. And it doesn't have to be an 800 calorie breakfast burrito, just something small, something potentially balanced. Like maybe you do, a mini scramble, or you do some oatmeal, but you put some peanut butter in there, maybe a handful of berries, or maybe you do a smoothie, something that you can kind of grab and go and satisfy your hunger needs, but can last you a couple of hours before you maybe need to go for your next meal, or maybe you get to work and you eat there. The regular eating, so you don't have to eat all the time. You're not grazing the entire day. But again, like I said, maybe every few hours you just kind of check in with yourself. So this is an example of, the timing of things. Maybe 9 o'clock you have something small. Maybe 1 o'clock you have something a little bit bigger. Check back in with yourself around 5:30 or so. And then the rule that people tend to say about going to bed and not eating so close to the end of the evening, there is some truth to that. The recommendation usually is don't let the biggest meal of your day be right before you go to bed, because you're not allowing your body to digest. It can affect your sleep. But also, as you'll see in the coming slides, coming up shortly, we'll talk about the morning insulin and the morning blood sugar levels. So it's possible that sometimes that could affect your overnight condition or your morning condition. So just be mindful of what that late night snacking or late night eating is. Next up, we have carb counting. So much like I think Natalia mentioned in there, just to give some guidance about this. If you are going to be on medicine, so usually carb counting is for people who are utilizing insulin, because as I said before, they might be injecting themselves or using a pump. and it has to offset the amount of carbs that they are ingesting. So usually the guidance will be, as you can see on the bottom, I want to clarify here too. Yes, we're calling it a serving size, a serving of carbs, not necessarily a serving size is what you see indicated on a label, but we're talking about if a particular food item has a certain amount of grams of carbohydrates in it, then you would utilize this mathematical method to determine how many quote unquote servings of carbohydrates are in that food. So as the example that I think Natalia gave, milk has maybe 15 grams of carbs for a glass of milk. So right there, as you can see on the bottom, that would provide you with one serving of carbs. So if your dietitian, your doctor, you get your guidance that you're seeing here as far as meal planning and your insulin dependence, you might have to limit carb servings for each meal as you see in front of you. So maybe at breakfast time, if you can do the math, right, 2 to 3 carb servings would be 15, 15, 15. So that would be about 30 to 45 grams total of carbs. Obviously, we want you to still continue, to balance out your meal with other things. But because your body is, in the case of type 1 or somebody who is using the insulin injection or a pump, the body has to offset that. So it has to know, how much am I eating? So this to me feels also could be a little bit overwhelming because you have to know what's in a food. You have to do a little bit of math, and then you have to, make sure you're adjusting your insulin injections or your pump accordingly. So on screen here, again, just an example of potentially what could be set up. So maybe lunchtime you have, salad with chickpeas and a piece of chicken and some other kind of side dish. And maybe that's about 60 grams of carbs total. So you've met that there. But if it goes a little bit over, you might have to wait a little longer to eat that extra part of your meal because your insulin needs to offset the carbohydrates that you're taking in. I hope that makes sense. For people who are, again, the diabetes educator would come and help somebody who's dealing with this and make sure that they have this on. They'll check them out. They'll do logs, and they'll, make sure that they're accordingly, because we don't want any of the numbers to go wonky if they don't understand what they're doing. Another thing I wanted to share with you here too, I'm a huge fan just data collection in general. I understand I just said before, tracking and weighing and measuring everything could be a little bit overwhelming, but I think if you collect some information, especially if you have the ability to track things on an app or otherwise, it can help. So if you are dealing with the diabetes diagnosis and you do have the ability to see and read, whether it's through those finger sticks or a continuous glucose monitor, to see what the range is over the course of the day, you can pinpoint different patterns. You can recognize what foods might trigger spikes and drops in your system. The Endocrine Society provides us with this guidance of what's known as time in range, or TIR. So this recommends that most people with diabetes aim for a time in range, we're talking about 24 hours of the day, of above 70%, right? So right there, above 70%, at least 70% of your day. I'm not going to do the math. 24 hours, 70% of the whole day within the range. So it's okay that your body might spike and might drop. So you can see in those last two bullets there, right? Less than 25% of your day should be in that high spike of above 180 milligrams per deciliter when you're doing your finger sticks or you're checking your blood sugar. And less than 4% of your day should be below, to drop really low. So again, this is just data you might be collecting through finger sticks or a glucose monitor, or you're testing things out maybe in your endocrinologist and you're getting an idea of those patterns happening there. And then you would need to know whether or not you need to make some adjustments to your food or to your medications in that particular case. Now, I want to point this out. If you are doing finger sticks, or somebody who's doing finger sticks, a lot of people don't realize that when they are told to check their blood sugar after they eat, 1 or 2 hours after they eat, it's not after the end of the meal. It's after the beginning of the meal. And again, bonus points if you know why. Because your tongue and your mouth contain enzymes that start the breakdown, the digestion, the digestive, physical, mechanical, chemical breakdown of carbohydrates in your mouth. So the second you put one bite in your mouth, that clock starts ticking. So set the timer for 1 to 2 hours, and then that will be when you will take your blood sugar after that period. You're not waiting until you're done with your meal, because that is quite arbitrary, right? Some people take I take 2.5 hours to eat one meal. Other people can eat in 15 minutes. So you need to make sure your body is going through that curve of spiking and dropping in order to know really whether or not you're in range and collect that data for yourself. Next up here, just another another reminder. Everything is related to everything. I've worked with so many people who manage their diabetes, either type 1, type 2, pre-diabetes, and sometimes they'll say, I'm doing everything and my blood sugar is still high, and they'll show me their food logs and it does look correct, but then they'll say their sleep is horrible, or they haven't moved around in a while, or that they're super, super stressed out. Hormones are affected by a lot of different factors, and these are three of those factors here. So if your sleep is really thrown off, both quality and quantity, that can affect your blood sugar. If you're stressed out, right, the brain, the gut brain connection, everything's related, friends, that can also affect your blood sugar levels. So can dehydration. We didn't mention that before. And physical activity can actually positively affect your blood levels. One of the best things that anybody with diabetes can do is when they are done eating, just move around for 5 to 10 minutes. Pick something, pick an activity. In my boyfriend's case, I bring him up a lot. In his case, he's on the pre-diabetes border there. So he does do finger sticks just to kind of gather some information for his doctor visits. And he definitely says when he walks around the block, he takes like a 15-minute walk very briskly. He notices a quick drop. But if he just like marches in place at home, there's really no difference there. So again, it's a very individualized approach of what works for you. And just one of the things, or three of the things that I wanted to share with people, that you could be doing all the right things when it comes to food, adaptations, trying to be conscientious of your carb intake, and things might still be wonky. All right. I'm going to share with you a few things here. This is also probably more related to people with type 1 and type 2, and definitely people who are on medicine. But in case you've never heard of these terms, we have the dawn phenomenon. I like calling this the vroom vroom effect. When our body wakes up, the cortisol, hormones, et cetera, they naturally kind of surge. And so people's blood sugar levels could be a little bit more elevated in the morning, and then they kind of have to wait for that to go down. Like I said before, you might wait until you eat, or you might have to offset your insulin or your medication on there. The waning insulin, so this is with somebody with a type 1 with the insulin pump. So here we have more like a blood sugar issue, or I should say insulin level issue, where it falls too low overnight, and then this occurs where the insulin is not set to provide enough for your overnight, again, the hormones that are kind of picking in, and it's possible that lasts into the morning or not. So again, if you're noticing blood sugar levels be a little bit wonky, especially in that morning time, this could be the issue here. The last one is known as the Somogyi effect. Whenever you see names like this, it's usually named after a doctor who discovered it, and here's a perfect example of it. Dr. Michael Somogyi, a chemist, actually a chemist who was the first to describe this back in the 1930s. So again, this is the body's response to low blood glucose, or low glycemia during the night. So if you're missing dinner, or you've taken too much insulin, again, your blood glucose levels are dropping, and in order to compensate, you end up waking up with a higher blood glucose. So your body's trying to always stay in balance, trying to always regulate. So again, keeping an eye on your data, making sure you're checking in. If you have your condition and you're being medicated for it, be conscientious there too, and make sure you're talking to your doctor to see how you can control it, figuring out what the culprit is, and changing maybe the time of your long-term insulin injections, or whatever your acting insulin is, and or utilizing maybe some of those other things, like being mindful of your sleep habits, maybe having to doctor up a little bit more with your food intake, or maybe having to include more physical activity to help offset all of that wonky stuff that's going on there. All right, misinformation. I thought I would share this too, because a lot of times we just got done saying with risk factors, right? There could be some weight issues, there could be some body fat correlations with putting people more at risk, but it's not only overweight people who get diabetes. And I say this also for future healthcare providers and current healthcare providers. Do not discriminate against people. Don't think just because somebody is in a smaller, leaner body that they're not going to have potential consequences and complications and be sick too. Like, that's just not the case, right? So we want to make sure not every person in a large body is going to have an unhealthy condition, and not everybody in a small body is always healthy. There is actually a term called lean diabetes to tell us that that is in fact the case. Not everybody is going to have a particular weight requirement in order to get it. It's all about insulin. It's all about the pancreas. It's all about those beta cells, and whatever happens there could, again, put you at risk for diabetes. The eating lots of sugar or carbs will cause it. No, we talked about this in one of the last episodes, one of the last webinars about this too. it's not great to overconsume certain things of any kind. And sometimes if we favor one thing over the other, yes, your body is going to try to have to figure out what to do with it. And if you're not very physically active, it could possibly end up increasing your overall body fat. And then that ends up putting you at risk for the condition. But it's not like I have a sweet tooth and therefore I'm going to get it. I want to point out something here too about family history and genetics, in the sense that if we when we look at statistics, we look at if you are genetically predisposed, it's usually about a 20% effect on your overall health outcomes, but 50% more is in line with your lifestyle modifications. So being mindful of what you're doing, take into consideration if you do have a family history of something, but it might not always put you at risk for those things. So the next one on here, insulin is the only way to manage. We just got done saying it is not, depends on what your condition is. There are a variety of different medications and approaches that can be given out in order to help you manage your condition. And last but not least, again, I get yelled at when I say this. I don't make the rules. This is the Endocrine Society and the Diabetes Association. It's not a curable disease. Unfortunately, it can be put in remission. You can quote unquote reverse it, but there still potentially could be the possibility that it would come back. So that's kind of, once you implement your modifications or once you're on that medicine, you might be on it long term, you might be on it lifelong. These are conversations that I want you to have with your doctor and your healthcare specialist. Speaking of healthcare specialists, support and resources. So whether you are dealing with diabetes or someone you know is, I just got what I said, the endocrinologist, your dietitian, your healthcare, your primary care physician. A lot of these people are there to help support you, provide you with resources. The prevent type 2 diabetes community that I had been trained in, those workshops are great. So if you happen to find one in your health center or in online, or what maybe your doctor provides you with some resources as well. And there could be support groups too. Like, this is often a little scary condition that people get a little concerned about. So if you're flying solo, it's always great to reach out. Just be careful about social media and the internet. Okay, be careful of some of the Facebook groups that you belong to. They don't always give the best advice, and not everything that works for one person will work for everybody. So you want to make sure that these are reliable, valid resources that you're looking into. As I said, they're here, right? Reliable resources. We have diabetes.org. We have the CDC, we have adces.org. A lot of these, anything that ends in an org or .gov usually are the good places to go to. I always like to end my wellness webinars on this next steps discussion: start, keep, stop. So when you listen to what I've talked about, if you are currently dealing with this condition or know somebody who is, what are some takeaways for you? You don't have to add it in the chat if you don't want to, but think about some of those things. What are you going to start doing? Maybe you start going to your doctor's visits. Maybe you start paying attention to that portion control or that plate method thing. Maybe, I don't know, you look for different label reading things and look at timing of things. What do you keep doing? Maybe there's stuff you're already doing that you're like, spot on. I feel really good about my habits and I'm going to continue doing that. And what are things that you might stop doing that are no longer serving you or that could potentially put you at risk in the future? So again, just kind of, I think this is a good time of year too, right? It's November. End of year is a good time to kind of reflect on things. And before we go into January and that new year, new you mindset, this is just maybe a nice time to take some inventory and reflect on how you're treating yourself these days and what maybe needs to be improved or continued. All right, friends, I'm going to wrap up with a few things here. First of all, thank you so much for being here. I always say there's so many people that register for the webinar. A portion of those people show up live. So if you're attending live today, thank you so much for being here live with me. The link to this recording will go out to everybody who's registered within the next week. And then in a couple of months, it gets posted for public viewing up on the Dish with Dina YouTube channel. Next month, our next webinar is going to discuss complementary and alternative medicine. That's CAM. So we're going to talk about different health and wellness modalities from around the world, what we do here in America versus what people do in traditional Chinese medicine or other approaches. And I think that's going to be kind of an interesting conversation to have as well. And so if you are interested in finding and following me / the Dish with Dina crew or brand, there's so many places online that you can come and check out. There is the YouTube video where I kind of tend to live. I'm not super on a lot of social media anymore, but YouTube is where everything lives and it's all free, right? So if I can help be one of the many people that you look to for guidance or one of the many online resources that you trust in, I would be very honored if you checked out the playlist. I'd love if you subscribed. I'm really trying to get up to more subscribers because as you can see, this takes a lot of time, effort, and energy, and it's so I really appreciate when people join, check things out, leave comments, share this information with other people, and just kind of get the word out there. So we have a whole playlist of wellness webinars. I think we're coming up almost 3 or 4 years now where it's been every single month of doing that. You can also check out my website, DishWithDina.com. There's a bunch of services on here. I do have a private practice. It is somewhat part-time, but I do see patients via telehealth across a lot of different states in the country, and I do take a lot of different insurances. So if you are curious or concerned about your condition, or you know somebody who could use some support and they qualify to work with me and they think I'm a good fit, please reach out and put them in touch with me. I'm always happy to help guide people. And if I'm not a great fit, I have a wide variety of dietitians I can always help put them in touch with or refer them out to. And because it's important for me to acknowledge and recognize research and evidence-based practices, I just want to give props to all of the resources that we took into consideration when we prepared this webinar. I don't just talk about things by making them up. I do my due diligence, and I look up a wide variety of online resources, research articles, and so many different things to make sure that you have all of the most updated and current and valid information. So thank you so much, everybody, for being here. I really appreciate it. I hope to see you again next month.